So I will invite Dr. Balakumaran to deliver his talk about TMVR, what the interventionist needs and does.
You must be feeling like you're in the lion's den, right? Are you the only cardiologist in the room?
No, I have another two,
Oh,
one
you brought you
electrophysiologist
brought
and
you
surgeon
brought you
there.
brought your bodyguards to the left and the right, right? Because it's obvious that there's like everybody saying the cardiologist,
Actually,
and
no known faces actually, except Pudiyavan, I think.
great. So you're getting to know a lot of us.
Oh, hi, hi,
Hey, hang on. You didn't call him to the gala dinner? If he had done some, gala dinner with us, he might have known some more of us. But anyway, okay, over to you, Dr. Bala.
Yeah.
We look forward to hearing this from you
Thank you.
because there's nothing more a radiologist needs or an imager needs than to understand what is needed and what is the perspective that you have.
Thanks.
So, TMVR,
Thanks
what
for
the
giving the
interventionist needs.
opportunity. Yeah. I think TAVR, I think most of us has a good experience, and TMVR very limited experience. We have a bit few number of cases, single digit only. But anything, our experience, just I thought I will discuss, and most of them are discussed by Dr. Vinith. So going into this, so you know that mitral regurgitation is one of the commonest violation with the high morbidity and mortality. And recognition of MR should include the assessment of etiology. What is the etiology? Whether it is a rheumatic etiology or due to the degenerative because of MAC or in a valve involved, we should be very clear, because rheumatic etiology only surgical is the only option. There is no options for any transcatheter valve replacement. So mitral surgery constitutes a first line therapy always. It's not like a TAVR. TAVR, it started with the ineligible patient, high risk, then come down to intermediate risk, now low risk also. But mitral while TMVR, still it is my surgical option is the first option, and the second option is only the transcatheter who are not inoperable and high risk for surgery. So for them only you can go for the TMVR or mitral clip. So there are many cases of even percutaneous double replacement. So in patient with suitable anatomy, mitral repair is the mitral clip, and repair is the most frequently applied procedure. In non-repairable patients, TMVR can be used and is a promising option. Thus, currently TMVR represents a new treatment option for inoperable or high-risk patients in failed bioprosthetic valves. Now, I think we are seeing a lot of failed bioprosthetic valves, because most commonly, whatever the good valve, it is degenerate over a period of 10 to 15 years, and we are doing good amount of procedures, mitral valve mainly in valve involved, not in MAC. And inoperable high risk with the native mitral anatomy who have a significant MAC. And going into that, advances in imaging has enabled the TMVR technique to evolve and becoming routine like TAVR. I think we have to wait and watch. And imaging has an important significant role, start from the transthoracic to severity of MR, etiology of MR, and TEE mainly in mitral clip, and again in TMVR also, and definitely CT. So these are the pre-procedural assessment. So we have the anatomy, assessment of the scallops, commissure, any prolapse is there. This is mainly for mitral clip. For like any prolapse, Carpenter classification, any cleft and mitral annular disjunction, and how much amount of calcium is there, max score. And chambers, yeah, LV dimension, EF strain, LA volume, IAS, where to puncture, and spontaneous echo contrast, who has high chance of thrombus, and for LA devices. So Doppler, color jet, everything. So I'm not going into detail in this. So there are contraindication, absolute and relative. IE definitely is a contraindication for any surgical or transcatheter replacement. And prosthesis dehiscence, again, there's no other options. And extensive prosthesis thrombosis, we have to wait and watch. And atrial septal thrombus. And relative contraindication is narrow LVOT. So generally our focus is mainly on LVOT. So we ask our radiologist to give what is LVOT, near LVOT. That is the main thing. And paraprosthetic regurgitation and LA thrombosis are all contraindications. Again, for anatomical factor is there is a estimated near LVOT less than 1.7 and less aortic mitral angle. And there is a more chance of coronary obstruction also. So we need a severity and coexistence of any degree of mitral stenosis, and to determine patient eligibility for according to the anatomic measurements. So pre-procedural echo is mandatory and always a first choice for a patient with suspicion of mitral valve disease, and it is non-invasive. So beyond TTE, TE and CT are the cornerstones. So again, the same thing, valve pathology, severity of MR, MS, and any MAC scoring, and geometry of LA, IVS, everything. These are adjunct to CT. So this is the patient, our patient. I'll show the cases. The bioprosthetic valve done almost 10 years back with a severe mitral regurgitation. You can see here. He came with acute LV failure and significant pulmonary arterial hypertension also. CT. So again, it's an essential imaging modality. I think I discussed, helps to provide information on the morphology of the wall and function of the mitral wall, an excellent incremental value, and to determine the annular size where we can land, and predicting the risk of postoperative LVOT obstruction and post TMVR, and evaluate the extension of MAC, everything. So CCT is employed to evaluate the patient's suitability. The most relevant aspects are mitral annulus measurement and mitral leaflet length, thickness, and calcification. IAS anatomy, where we have to puncture, because each mitral clip and TMVR and LA appendage, we have to have a particular point. Most commonly for TMVR, we need an infra-posterior approach so that we have more space to work. So again, this is a saddle-shaped annulus and a D-shaped annulus. So this D-shaped annulus doesn't involve the aortic continuity. The saddle-shaped annulus involves the aortic continuity also. And based on this, the LOT obstruction is more or not, we can predict. So these are some TMVR devices, and FDA approved is Sapien 3 and Cardia valve. So again, this is the valve-in valve, most commonly are doing, and valve-in ring, we have to be very careful at deploying. There are chances of popping out of the valve also, and valve-in MAC. There should be significant amount of symmetric calcium to go for the valve-in MAC. So again, sizing, I think all CT will give how much to size, how much you can overestimate, whether it's a LEOT risk is there. So we all has to estimate like animation 3D, like how much new LEOT area post deployment of the TMVR, then only we should go ahead. So the calcification, MAC calcification, there is a mild is a total score is 2, moderate is 5, and severe MAC is 8. More than 7, relatively okay for a Sapien valve. So MAC complicates both surgical and transcatheter mitral interventions. For surgical interventions also, it is technically difficult because we can't place the suture there. If inadequately debrided, there are chances of any PVL, and there are, because the circumflex artery will go behind that, the chances of circumflex artery injury also. So MAC is ideal for devices that anchor by radial force, especially for the Sapien. And for the Sapien, anchor is better if there is a circumferential calcium involving more than 75% of the annulus perimeter. We need a good amount of calcium also. So generally for even TAVR, good amount of calcium is needed. Otherwise, that's why TAVR is not recommended for the young patients who doesn't have any calcium. Because for holding the valve, the radial force, we need a good amount of calcium. So CT-based MAC score can predict the anchoring and risk of valve embolization. I think as Dr. Vinit has discussed. So patient with a MAC score less than or equal to 6 have 60% embolization and migration rate, whereas MAC score more than 7 has only just 9.7%. And valve oversizing also is an important part of valve in MAC to maximize the surface area, but also we have to see the LEOT also. If you oversize more, there are chance of LEOT obstruction. So there is a higher risk of a TMVR because most of the times in TMVR we will oversize the valve. So, and the incidence of LEOT obstruction for all TMVR techniques like valve in MAC can be decreased by adequately identifying the patients by calculating the neo-LEOT area and skirt LEOT area. So fundamental to the TMVR procedural success is a valve process that allow for adequate anchoring and sealing. So such a device, however, carries a risk of narrowing the LEOT and display the native anterior mitral leaflet. Again, he has mentioned length more than 30 mm, again is a relative contraindication. So historically, LEOT obstruction has been considered rare, but recognized complication following surgical interventions. But after a TMVR, it has a significant role. So predicted neo LEOT is a result of the dislodgement of the anterior leaflet mitral wall towards the ventricular septum and can be calculated by a CT. So if a predicted neo LEOT area less than 200, definitely there is a chance of LEOT obstruction, and we have to be very careful. So these are the things. So prevalence is more than 50% referred patients for not suitable for TMVR is because of the LEOT obstruction risk. And there are options. We can do a surgical. Obviously, we are doing TMVR for non-operable patients, and we can do alcohol settle ablation. Say lampoon. It's like a basilica we are doing for the TAVR. We can do a lampoon for a TMVR, but riskier. So you can see here is the prosthetic valve. You can keep it here, and this is a LEOT. So there are chances of neo LEOT. This area only we should calculate, and if it is more than 200, we can go ahead with the TMVR. Again, aortic mitral angle. So wider the aortic mitral angle, it's good. It's lesser. There are chance of, again, there is a chance of LEOT obstruction. So you can see here, there's a LEOT, and there's a displaced EML after the device, and this is the neo LEOT. So this neo LEOT only we need. So there is another term called a skirt neo LEOT. That is the distance between the skirt and this. So now the recommendation is we have to measure the near LVOT and skirt near LVOT also. But if you're taking both near LVOT and skirt near LVOT, then we won't get any TMVR cases, because most of the times the skirt near LVOT will be very lesser. So same thing like aortomitral angle, septal hypertrophy. These are the chances of near LVOT obstruction. So we can do alcohol septal ablation, and then we can go to the procedure. Again, there is a thickness more than 30 millimeter is a contraindication, because there are chances of LVOT obstruction. So this LV management algorithm, if neo LVOT less than 200 and anterior leaflet is more than 22 or 30, definitely no for transcatheter. If it is less than 200, we can take a skirt LVOT. Skirt LVOT less than N180, so we can do the all modifications, and then only we can go for a TMVR. So, but most of the times, I think if you are taking together both near LVOT and skirt near LVOT, we won't get any cases and all. So we can see the near LVOT if less than 200, yeah, it's reasonably okay. We can manage. Mainly in valve involved. Again, MAC, it is going to be very scare. So same thing with the alcohol septal ablation, it is ablated, and then we can safely deploy the valve here. This is a lampoon. It mimics the surgical technique of the resection of the anterior mitral leaflet to prevent the LVOT obstruction. This is an animated view here. Just same like a basilica, perforating that and snaring the wire. Basilica most of the time we will do for a TAVR valve involved. These are the same thing. Just is perforating the leaflet. So again, the CT provides the information on landing zone, because most of the times we land 80% of the ventricular and 20% of the atrial subset. So we can know where to land based on the MAC, AV shelf, and annular distension. So CT provides accurate estimate of the calcium severity, extent and density. So again, IAS puncture also very important, because any previous past history of surgery, they are approached to IAS, because it will get fibrosed and very difficult to puncture also. So CT plays an important role, because it's a thinned out septum, everything, it will give the idea. So although there are no formal guidelines, the preferred puncture for a TMVR generally is infra-posterior, and for a mitral clip generally it is superior and posterior. So that's why IAS intra-atrial septum anatomy we can get via both the TE and CT. So this is the approach here, and mostly we go via superior and posterior approach, an infra-posterior approach for TMVR. So we are puncturing here. There's a valve involved with it. The pigtail is a landmark. So venous access most of the time won't be issue like arterial access for TAVR, and always we'll rule out anomalies. So this one, I think same like a D-shaped annulus, just anatomical, and both 3 Mencio softer. There's a AML, and there's a medial trigone and lateral trigone. These are the things. So again, this is a neo LVOT area, and how to calculate this line between the mitral annulus and then along the aortic annulus. This angulation. Again, post-procedural assessment, positioning of the device, assessment of the mitral valve reagitation, again chamber sizes, how much reagitation was there, these are the things. So immediately after TMVR delivery, attention should be given to the initial hemodynamic changes and the use of TEE to assess any complications, whether there is a displacement of the valve or there is LVOT obstruction, again pericardial effusion also. So there's a TMVR induced LVOT obstruction here, and there's a malposition, almost the valve popped into left atrium here. So you have to do open only. So again, these are the post-procedure imaging. We can show there's a thrombus is there, any LVOT obstruction, pseudoaneurysm, other malposition TVR wall. So this is a lampoon. So the other thing that this patient had a neo LVOT area less than 200. So like bifurcation stenting, we can keep one balloon in LVOT, and the same time we can deploy the valve here, so that we can push the valve little towards the mitral ventricular side. But always this we can do and only in ECMO, not under conscious sedation and all. Yeah. So this is the post. So this is a 72-year-old gentleman. This we did, I think, almost 7-8 months back. So admitted recent worsening of breathlessness and class 4 dyspnea with symptoms of right heart failure also. So previously myxomatous severe MR with done on the 29 perimount wall, perimount plus, it's a reasonably good wall. You can see the transthoracic, almost significant mitral regurgitation. Sometimes it will be underestimated in transthoracic echo, 2D echo. The TE, you can see the significant MR. Patient was very symptomatic with elevated liver enzymes also. So IAS, everything we can see via this. So because high risk for open redo mitral replacement, so options of TMVR valve in valve was given, and we can estimate based on the valve what was implanted before. So this is our could even only help. So TE before procedure. This is the plain scene of mitral valve processes. Puncturing the intra-atrial septum. We cross the valve with the Achilles sheath and place the pigtail in LV. Dilating the intra-atrial septum for tracking the device inside. That's why we need more space to work in the LA. Again, if IAS is fibrotic because of the previous surgery, it is very difficult to track the valve because it won't get dilated also. It may. The valve was placed inside. Checking the thing. So along the ventricular, 70 to 80%, 20% across the atrial side. Yeah. So deploying the valve, finally you can see it is pushed inside, somehow pulled it and deployed. Some of the last minute, just like, so you have to concentrate till the last second. Otherwise, valve would have popped out into the LV. You have to snare, and most of the times very difficult also. You can see here, just pushed it and pulled it in. So two things. The final LV angio, no MR, nothing. So patient had some ST elevation inferiorly, just check the RCA whether anything is there. Nothing was there. So it's stable now. This is a post TMVR valve in valve. There's no MR also. You can see here perfectly deployed. This LA contrast is there. It will settle down generally. So conclusion, TMVR represents the treatment of choice for all patients with mitral valve disease who deemed unsuitable for cardiac surgery. Multimodality imaging is necessary, and definitely TE and CT plays an important role because it provides the near LEOT risk and landing zone, everything. Thank you. Open for discussion. Thank you.
Thanks, Dr. Bala. That was a brilliant talk, and I tell you, beauty lies in the eyes of the beholder. I just love the cases. But yeah, so I think one thing also is important for everybody to realize is that when you're looking at the interatrial septum, please do the CT, because sometimes there's so much calcification in the interatrial septum, and they'll go in and they'll need to puncture it, and they won't even realize where to go in from. So it's really an important, critical thing. The other thing is getting the angle right, where to actually puncture. So all those things need to be delineated for them so that when they go in, they're not, looking for where they have to.
So do you sit with the radiologist at the console, understand your angles, or you rely on the radiologist to get the report?
No. For most of the TAVR cases, we'll discuss with them everything before, and even after the echo, I will discuss with our radiologist.
That's a good practice. Yeah, yes, good.
Most of the times we'll discuss.
Good.
Usually,
Any questions?
I already discussed AST. Generally, we won't do CT. Most of the times, TE
See, the
will give more
contrast in the
information.
both atria prevents you from seeing a small atrial septal defect. So that's a problem there. Yes.
And generally, like post ASD device closure, we won't send for CT anything because mild residual shunt is acceptable. And
CT will not show you the leaks. CT will only show you device if it's not, and probably some compression of some organ if it is
that
there.
we have a
or
3D
any
TE that is
complication.
more useful actually.
In any case, in any private hospital, it's very difficult to do a post-procedural CT for everybody. You really need to justify the cause and the cost. So
So there is no case for actually doing CT there, like vessels
No,
there.
like lots of towers you would love to have how well it is open and all, but it's very hard to.
No, actually, I was trained in China. There, actually, routinely they will do the pre-MRI workup, post-MRI, pre-CT, post-CT for all the patients actually, because all covered under insurance. Here, very difficult because till the last minute, you know how much when patient is getting discharged, how much will be there.
I agree. And the other thing is that you see, if you think of it, in a post-surgical valve, we will never accept even minimal, leak. But in a TAVR, we've been for a long time been accepting minimal mild. But I think now we're getting better with a lot of balloon dilatation. I think it's much better now. But great, thank you so much. Any questions from the audience? Or a big round of applause to our cardiologist who's been kind enough to spend a Sunday morning with us. You've been very, very useful. We've learned a lot from you. Thank you so much.
Thanks, ma'am. Thanks, Pudevan, and thanks to KMCH for giving me the opportunity. Thank you.
Thank you.
We should felicitate Dr. Balakumaran, sir, please. I request Dr. Priya ma'am to please felicitate doctors.